The human neck is a densely packed neurovascular highway. Right in the middle of it sits the thyroid, a 25-gram metabolic engine. This organ governs basal metabolism and calcium homeostasis by synthesizing thyroxine, triiodothyronine, and calcitonin, hormones that set the pace for nearly every cell in the body. Treating thyroid pathology often means extracting this highly vascularized mass. For a surgeon, the challenge is removing the tissue without clipping the delicate nerves that control the vocal cords, or accidentally stripping away the tiny glands that manage the body's calcium levels. Successfully navigating this space requires an understanding of how the gland was constructed. To master the adult anatomy, the surgeon must first look at its embryonic origins. The thyroid's anatomical journey begins in the 6th week of gestation. It starts as a median bud forming at the foramen caecum, right at the base of the developing tongue. From there, a hollow tube called the thyroglossal duct migrates caudally down the neck. As it descends, it passes in close continuity with, and sometimes directly through, the developing hyoid cartilage. As the main lobes descend, they rendezvous with a secondary component, parafollicular C cells. These originate from the neural crest and travel via the ultimobranchial body, emerging from the 4th pharyngeal pouch to merge into the main thyroid mass. This specific migration path dictates common anatomical anomalies. Tissue left behind along the duct can form thyroglossal cysts or leave ectopic thyroid deposits scattered down the midline of the neck. Because the thyroid traces this convoluted path during gestation, its final position in the adult neck is permanently locked into a specific neurovascular map. Zooming in from that gross anatomy, the functioning unit of the thyroid is the lobule. Each lobule is packed with 24 to 40 individual spherical structures called follicles. Looking closely at a single follicle, you can see a distinct outer ring lined with cuboidal epithelium. These cells encase an inner reservoir filled with pink colloid, which stores the glycoprotein thyroglobulin. Hormone synthesis begins as epithelial cells trap inorganic iodide from capillary blood, pulling it across the membrane. Inside, iodide oxidizes and binds with tyrosine on thyroglobulin, forming iodotyrosenes. These couple into active hormones, T3 and T4, stored directly in the central colloid reservoir. T3 is a fast-acting hormone, whereas T4 serves as a circulating reserve, converted by peripheral tissues into T3 as needed. The thyroid's massive blood supply and complex adult architecture exist specifically to feed this iodide into the follicular assembly line and flush active hormones back into the blood. This cellular assembly line is governed by the hypothalamic pituitary thyroid axis. Operating on a negative feedback loop, the brain detects low T3 and T4, prompting the pituitary to release TSH. TSH forces follicular cells to break down thyroglobulin, releasing active hormones into the blood. As levels rise, the pituitary stops the signal. In hyperthyroidism, such as Graves' disease, this feedback loop breaks. Antibodies mimic TSH and continuously bind to receptors, forcing follicles to pump hormones even as the pituitary shuts down. Surgical intervention becomes necessary when this biochemical governance fails, and the gland's hormone output can no longer be regulated medically. Zooming back out to the gross anatomy, sustaining this overactive metabolism requires a massive blood supply. The gland is fed primarily by the superior and inferior thyroid arteries, which form a rich, interconnected network of anastomoses across the tissue. The posterior capsule is the highest risk territory for a surgeon. Lying just underneath the gland is the recurrent laryngeal nerve. Because of its embryological development, this nerve is asymmetrical. On the left, it recurs around the arch of the aorta and runs medially. On the right, it loops around the subclavian artery, taking a more oblique path toward the larynx. Surgeons navigate this area by locating Baer's triangle. The carotid artery, the inferior thyroid artery, and the recurrent laryngeal nerve form the 3 borders used to isolate the nerve's path. While the clinical goal is removing the pathology, the technical challenge is preserving the patient's voice by respecting this neurovascular geometry. The point of maximum surgical vulnerability is the ligament of Berry, a dense condensation of pretracheal fascia. This ligament physically binds the thyroid to the trachea. It is precisely here that the recurrent laryngeal nerve is at the highest risk of being caught or severed during mobilization. This posterior surface also houses the parathyroid glands. Their variable positions are a direct result of their embryological descent from the third and fourth pharyngeal pouches. The surgeon must preserve these tiny glands and the minute arterial arcades that supply them. Accidentally removing them or cutting their blood supply leads to a dangerous postoperative drop in calcium. The millimeter by millimeter dissection required here is the inevitable result of how tightly these distinct tissues fuse together during gestation. Clinically, thyroid pathology follows a pattern. It is a macroscopic exaggeration of microscopic physiological derangements. In mountainous regions where dietary iodine is scarce, the gland cannot produce enough hormone. To compensate, the tissue undergoes diffuse hyperplasia, creating a simple endemic goiter. Fluctuating periods of stimulation eventually cause follicles to fail. They undergo central necrosis and are replaced by inactive colloid nodules, leading to a large multinodular goiter. In Graves' disease, the follicles are hyperactive. Under a microscope, they show high columnar epithelium and empty acini, leaving a characteristic scalloped pattern in the remaining colloid. This cellular overdrive manifests as a diffuse, symmetrical swelling in the neck, often accompanied by the characteristic eye signs of primary thyrotoxicosis. Whether the expansion is driven by a lack of iodine or an excess of antibodies, the sheer volume of the resulting mass makes surgical intervention a mechanical necessity. When medical management is exhausted, a total or near-total thyroidectomy provides the definitive solution for toxic nodules and severe goiters. The procedure begins by gently separating the cervical strap muscles and ligating the superior and inferior thyroid vessels to manage the gland's intense vascularity. The surgeon mobilizes the gland laterally to expose the tubercle of Zuckerkandl, identifies the recurrent laryngeal nerve within Bear's triangle, and frees the ligament of Barry. The diseased endocrine engine is finally decoupled from the neck, leaving the critical nerves and parathyroids intact. A successful thyroidectomy is an exercise in reverse engineering. It allows a surgeon to safely dismantle an overactive biochemical mass by following the blueprint laid down during its embryonic descent.